So the phase 1 had multiple different dose levels, and so we were exploring, quite literally in real time, what the best way to deliver this combination was. We were making decisions, admittedly, based upon modestly sized cohorts of patients, but I think the decisions that we made, now 2.5 years ago, about how to design this trial were correct, because we saw a very good balance between safety and efficacy. Now, we can't forget that there were 55% of patients receiving this combination who had a grade 3 or 4 adverse event. That's unmistakable, and that's been consistent. In fact, it's a little bit lower than in the phase 1, which is great, because the phase 1 was conducted by 2 expert institutions, Yale and Memorial Sloan Kettering, and so we were expected to be able to treat patients safely. But the fact that we were able to deliver this therapy at 137 sites globally to 945 patients, a third of whom got the combination, with no treatment-related deaths in the combination, to me was very important, and it showed that we could strike a good safety efficacy balance, because in that combination cohort, not only did we see the highest response rates as well as the longest progression-free survival, but we also saw no drug-related deaths. And interestingly, clearly the rules about when to stop treatment are good rules, because we saw that in the patients who stopped treatment with the combination, which was about 37% of patients, 67.5% of those patients who stopped treatment had an objective response. And half of those developed that response after they stopped treatment. So I think that we have set some good standard rules for how to apply this therapy that clinicians can use if it should become widely available.